Bona tarda, benvingudes i benvinguts a la conferència Rehabilitació neuropsicològica i prehabilitació en epilèpsia, organitzada per la secció de neuropsicologia del COP. Abans de començar us recordem que l'activitat tindrà una durada d'1 hora i 30 minuts, amb una primera part de ponència i un espai final destinat al torn de preguntes, en el que podreu participar a través del xat. Us recordem també que aquesta conferència es realitza en anglès i que disposeu del servei de traducció simultània al català. Per escollir l'idioma, haureu de clicar sobre l'opció Interpretació que trobareu a la barra d'eines de Zoom, que està a la part inferior de la pantalla. L'activitat serà impartida per la doctora Sally Baxendale i coordinada per la Carmen Pérez. La Carmen Pérez és doctora en psiquiatria, llicenciada en psicologia per la Universitat de Màlaga, amb màster en neuropsicologia i neurologia de la conducta per la Universitat Autònoma de Barcelona. Té 10 anys d'experiència com a neuropsicòloga clínica i investigadora a la unitat d'epilèpsia de l'Hospital del Mar de Barcelona. Actualment és coordinadora de la unitat de neuropsicologia i neurorehabilitació de l'Hospital Nou Delfos de Barcelona, l'Hospital Vitas Màlaga i Xanit Internacional. També és professora associada del màster en neuropsicologia i neurologia de la conducta de la Universitat Autònoma de Barcelona, vocal de la Junta de Govern de la secció de Neuropsicologia i del Comitè d'Acreditacions de Neuropsicologia Clínica del COP. Us informem que la sessió sí serà gravada i que l'organitzador prohibeix expressament el registre audiovisual i la posterior difusió o exhibició de l'imatge en qualsevol suport, ja sigui material o electrònic. Així doncs, iniciem l'activitat. Quan vulguis, Carmen, pots començar. Moltes gràcies.
Muchísimas gracias al Departamento de Formación y bueno, damos paso al inicio de esta actividad. Voy a presentar a la doctora Baxendale, lo haré en inglés, ¿vale? Paso al otro idioma. Today I have the pleasure to introduce Professor Baxendale. Dr. Sally Baxendale is a professor of clinical neuropsychology at the UCL Queen Square Neurology Institute, a global leader in neuroscience. She has over 3 decades of clinical experience working with people with epilepsy in London and Oxford, and is the current chair of the Diagnosis Method Commission of the International League Against Epilepsy. She is on the board of governance of the International Neuropsychological Society. She is a specialist in neuropsychological assessment of cognitive and behavioral difficulties in epilepsy and in non-pharmacological intervention for this disease. I'm sure she will offer us a very qualified view on neuropsychology in epilepsy as a tool for non-pharmacological intervention and a line of research in continuing progress. Without further ado, I give the floor to Dr. Professor Baxendale. Thank you so much, Professor.
Thank you very much, Carmen, and thank you for inviting me to speak to the group this evening. I'm very grateful that you've all turned up on a Tuesday evening to hear about the neuropsychological rehabilitation and prehabilitation of people with epilepsy. So just so that you can see where I'm going to be going over the next hour or so in terms of the talk, I'm first of all going to talk a little bit about the principles of cognitive rehabilitation in epilepsy. And once we've established those, I'm going to go on and talk about how we can apply those principles when we are preparing people for epilepsy surgery and the sorts of cognitive difficulties that people may experience when they undergo epilepsy surgery. So I'll be talking about how we assess neuropsychological outcomes following epilepsy surgery. I'll be talking about the different types of neuropsychological outcome that happen after epilepsy surgery, because we can group these into different types of group, and then talk about how we predict post-operative decline and how we prepare patients for a post-operative decline. So that's the structure of the talk for this evening. So when we look at the cognitive rehabilitation literature in epilepsy, There are many, many papers that have been published on this, and it's clearly recognised as an important clinical need in this group. So it's understood that people with epilepsy suffer from cognitive difficulties, and that we need to implement some strategies to try and help them. And there are many, many excellent reviews of the literature. And when you look, there's approximately one review of the rehabilitation literature published every year. But unfortunately, there are more reviews of the literature than there are actually studies that have looked at how to help these patients and what to do with cognitive difficulties in this group. So the reviews outnumber the interventional studies, and that ratio is actually getting worse as the years go by. We are getting more and more reviews and fewer actual studies of what to do. And if we look at the conclusions of the reviews, they're all very, very similar. So they will all say that there's a lack of evidence, that there is a clinical need, that this area is under-researched, or even overwhelmingly under-researched. There's a lack of research, insufficient research. All of the reviews always say the same thing: we need to do more, but we don't do it. And we just have another review the following year saying the same thing. So why might that be? Why is there a lack of studies of methods that could help the cognitive problems that people with epilepsy have? A lot of the reviews and the people who work in this field will say, well, there's a lack of resources. So rehabilitation, cognitive rehabilitation is very, it requires a lot of time, it requires a lot of effort, and there just aren't the facilities, there aren't the neuropsychologists, there aren't enough psychologists to really do the work. So sometimes people will argue it's a lack of resources because it's too time and labour intensive. Another reason that has been put forward for the lack of empirical studies into rehabilitation is that there really isn't the funding for it. So if we look at treatments for seizures in epilepsy, many of those are funded by the pharmaceutical companies. So pharma will fund the studies looking at whether a medication works, but we don't have that for cognitive difficulties. So it may be a resource problem, it may be a funding problem, but really that's not the whole problem. And it really goes back to the way that we diagnose epilepsy. So right back to the beginning. So we need to think about how epilepsy is diagnosed. So if we think about epilepsy as a medical diagnosis, really what we are diagnosing is a symptom. So you get a diagnosis of epilepsy if you have seizures, but seizures themselves are really just a symptom of something that's gone wrong in the brain. So there's some reason why the brain is producing seizures. And that's different to many of the other neurological conditions that we work with, where somebody is not diagnosed on the basis of a single symptom, but they're diagnosed on the basis of an underlying process. So in something like multiple sclerosis or Parkinson's disease or motor neuron disease, or all of the different types of dementia, that diagnosis is given on the basis of what's happening within the brain. Whereas epilepsy is diagnosed on just one symptom of an underlying brain abnormality. There are many, many reasons why somebody may experience a seizure. And that's why people with epilepsy are such a heterogeneous population. And because we just focus on one aspect of the underlying brain abnormality that means somebody is likely to have seizures, this can be problematic for clinicians and patients and their family. And this is why, because we're really, really focused on seizures. As soon as somebody presents with a seizure, we're looking at where that seizure is coming from, what that seizure looks like. We're counting those seizures. Patients are encouraged to keep a diary of how many seizures they have. We really look at what that seizure feels like for the patient. Everything is focused on the seizures. But there are lots of other things that come with the abnormality that's causing the seizures. So if, for example, somebody has hippocampal sclerosis, they may well have memory difficulties that they experience every single day as a result of the hippocampal sclerosis. And they may experience a seizure once a month as a result of the hippocampal sclerosis. But both the seizures and the cognitive problems are symptoms of the same underlying disorder. But we've just picked out one. When we look at epilepsy, we just pick out seizures. We don't really focus on the cognitive problems, even though they are both part and they both stem from the same underlying abnormality. And it's not just cognitive problems. Depending on where the seizures are arising from, somebody may have behavioral difficulties, they may have increased levels of anxiety, and they may have increased levels of depression as well. And that depression is not necessarily a response to the diagnosis of epilepsy. We know for many people that depression actually predates the onset of seizures. So it's a symptom of something going wrong in the brain prior to the onset of seizures. It's, again, all of these things are symptoms of the same underlying condition, but we're just focused on the seizures when we give somebody a diagnosis. Now, it is recognised, clinicians and classification systems certainly recognise that cognitive difficulties, behavioural difficulties, and neuropsychiatric difficulties are commonly seen in epilepsy, but these tend to be classified as comorbidities. And the problem with comorbidities is that a comorbidity is the presence of one or more additional conditions that co-occur with a primary condition. But actually, these aren't co-occurring conditions. They come from the same underlying pathology. So they're just a different symptom of that underlying pathology. So they're not something separate. And the idea of a comorbidity really indicates that they are, and they're not. They come from the same underlying pathology in many, many cases. So because they tend to be conceptualized as something secondary and something different from seizures, these difficulties are not always covered in diagnostic consultations. So when somebody is first diagnosed with epilepsy and they meet with their neurologist, there is a lot to cover. There's a lot to talk about. So people have to talk about safety, living with seizures, how to keep yourself safe. They talk about sometimes the risk of unexpected death in epilepsy. There's a lot of focus on monitoring seizures, how often they're occurring, when they're occurring, what happens during a seizure. And because there's all of this information to get through, sometimes the discussion about some of the other things that can happen when you develop seizures and you're given a diagnosis of epilepsy, those things aren't covered in the consultation. And not only are they not covered, but the treatments that we give to control seizures, and whether that may be anti-seizure medications or surgery, can make the cognitive problems worse. So quite often this is not properly covered by the neurologist when they see the patient and they first get that diagnosis. And if it's not covered right at the very beginning, if the patient is not informed at the beginning of their patient journey when they first get the diagnosis of epilepsy, that cognitive difficulties could be part of the condition, it's often seen by the patient and also by their families sometimes, and sometimes even by their clinicians, as something separate and something different. So it's not unusual for me to see in my practice somebody who has had epilepsy for many, many years, referred for a cognitive review, who is completely unaware of the relationship between poor cognition and cognitive difficulties and their epilepsy. They think it's something different, they think it's something separate, and they get very, very worried when they start to develop cognitive difficulties. And this can cause really quite profound anxiety when they start to worry that there's something else going wrong with their brain and when they've already got epilepsy. And that anxiety itself can exacerbate the underlying problems. So a vicious cycle is set up where somebody starts to worry and really focus on their memory difficulties, and then the memory difficulties get worse, and then that makes their worry worse, and so it goes on. So although we are psychologists and neuropsychologists and we are experts at cognitive rehabilitation, the first thing that I would argue is that actually cognitive rehabilitation doesn't start with us. It starts in the neurology clinic. It starts when the patient is first investigated and confirmed and diagnosed with epilepsy. The waiting list for a neuropsychological assessment in most services, in most countries, is very long. We don't have lots of neuropsychologists, so people wait a long time, and it's quite a scarce resource. So the role of the neurologist is really important in managing some of the memory problems before they get to see their neuropsychologist. So they play a role in educating the patient, telling them why they might have memory difficulties, working on acceptance that this is part of having epilepsy, and preparing the patient for us to see them so that they're in the best place to benefit from our input when they get to see the neuropsychologist. So really rehabilitation starts in the neurology clinic, and it's our job as neuropsychologists to get this message across to the neurologists. They need to understand that when somebody is diagnosed, they need to be talking about cognitive difficulties. They need to be telling the patient that this is a possibility, that this is part of the condition, so that they're aware of that right from the very, very beginning. Because there are lots of reasons why a neurologist should be interested in cognitive function. Even before somebody is diagnosed with epilepsy, if they ask about cognitive problems, it can be diagnostic, it can be really helpful. So with temporal lobe epilepsy, we would expect these people to be reporting cognitive difficulties. If you don't ask and you're just focused on the seizures, then you won't know about that. So actually, just even before you get to the diagnosis, it can be useful to ask about memory difficulties. And also, just by asking about memory difficulties, it makes it clear to the patient that this is something that the doctor is interested in. It's something that's relevant to their condition. So right from the beginning, it's there, it's relevant, the doctor's interested in cognitive difficulties. When somebody's diagnosed with epilepsy, we need to explain that the seizures are one symptom of brain abnormality, and there may be others, and cognitive difficulties may be some of those. Right from the very beginning, that's part of receiving the diagnosis of epilepsy. And when your neurologist refers somebody for memory rehabilitation or cognitive rehabilitation, they need to be very clear to the patient that there are many, many reasons why somebody with epilepsy might experience cognitive difficulties. It could be part of normal aging. It could be just another symptom of the underlying pathology. It could be due to stress and anxiety, hormonal changes, medication, lots of factors. And that information, they don't need to wait to see the neuropsychologist to be aware of these factors. And if they're aware of these factors when they are first referred, it considerably reduces the anxiety whilst they're waiting for an assessment and when they actually get to see the neuropsychologist. So before we come anywhere near the patient, it would be really great if the neurologists that we work with have done this groundwork with the patient, and that's part of their part of the work that they do when they're diagnosing patients and when they're talking to them about the impact of living with epilepsy. So cognitive rehabilitation doesn't start with us. It starts with the neurologists in the neurology clinic. The other thing that really it's the responsibility of the neurologist to do is prepare the patient to make sure they are in the best possible place to benefit from any input that we can give as psychologists. So we want to make sure that if there are difficult medications that the person is on, if they're on medications that have a very significant impact on processing speed or word finding difficulties or some of the other cognitive side effects of the medications, that is optimized. If the person can come off that medication, then that would be good. If they can't come off that medication, that they are on the lowest possible dose, if that is possible. Obviously, we are always trying to balance seizure control with side effects, but it's something that sometimes needs to be looked at. It doesn't happen as often now, I'm very pleased to say, but certainly it wasn't that long ago when some people were just on huge amounts of anti-epileptic medications. One medication didn't work, and then the doctor would just add another one, and then just add another one, and then just add another one without actually taking any of the other ones away. And I've certainly seen some patients who were highly sedated by all of the anti-epileptic medications they were taking, that weren't really doing anything at all, and that can be rationalized. We tend to see that more in institutionalized patients in our country. I'm not too sure what it's like in Spain, but certainly we do see that sometimes in our country. So we need to think about medication. We need to think about interictal, subclinical and EEG abnormalities that may be interfering with cognitive function. And just be aware that they may be happening, because that's something that will help us to understand why somebody is reporting cognitive difficulties. We need to be aware of mood. So if somebody is very anxious, or if they are very low in mood and depressed, that can have an impact on their cognitive function, and that's something that can be addressed by psychiatry, via anxiety management, and via antidepressants if necessary. It's also quite important to really explore somebody's motivation and how motivated they are to really address cognitive difficulties, because it's not a passive thing. When you come into cognitive rehabilitation, the patient has to work quite hard and has to do all sorts of things to really optimize their function. If they're not motivated, then it's not going to work. So we need to be clear about motivation. And we also need to talk about quality of sleep and seizure control, and get these things optimized before we get anywhere near any kind of rehabilitation strategy. So once we've done that, and that's quite a lot of work to do before somebody even gets into the kind of rehabilitation program. So I think a lot of the time when somebody's referred for cognitive rehabilitation, people just think, oh, well, they're going to be taught about strategies. But there are so many steps that we need to do before we get to any training in strategies. And those are the ones really before they even get to the psychologist. If you can train your neurologist up correctly, they can be doing a lot of this groundwork, so that when the patient gets to you, they're all ready to receive the help that we can give. So the first stage in cognitive rehabilitation in epilepsy really is education. So in our centre, we always start with, really, it's almost like a little training course in psychology, basic psychology. So we talk about how memory works, how it goes wrong, why it's disrupted in epilepsy, all of the different types of factors that can influence memory function in epilepsy, and the impacts of treatment as well. So we teach them all of the memory fallacies and the memory myths that the general public tend to hold. So memory is not a video recording of what happens every day. It's changing all of the time. Memories can be manipulated. Quite often, memory difficulties aren't memory difficulties at all. They're attention difficulties. We just don't attend to the information, and that's why we can't remember it later. So all sorts of things we do, just teaching people about memory, how it works, and how it goes wrong. So they've got a good understanding, a good basic understanding of basic neuropsychology. And that's what we start with. And once they understand how memory works, how it goes wrong, we really work on accepting that cognitive difficulties are part and parcel of having epilepsy. It's part of the condition. So accepting that in the same way that sometimes we can't completely control seizures, sometimes we can't completely get rid of the cognitive problems that come along with the diagnosis of epilepsy, because there is something in that person's brain, the way that that person's brain is put together means that their memory or other cognitive problems are going to exist. So that's what we're working on when it comes to acceptance. And that's why it's really important that this is done early on in the patient's journey when they're diagnosed with epilepsy, so that they've got this understanding at the beginning, because that really helps them to accept that cognitive difficulties are part of the condition and that there are no magic answers when it comes to getting rid of them. We can certainly help to reduce the nuisance that they cause in everyday life, but we can't get rid of them in many, many cases. So the earlier that they understand that, the better, and the more able they are to accept that. So education and acceptance can take some time, and it's only when you've got those 2 steps completed that you really move on to the 3rd, 4th and 5th steps, which are strategies, outsourcing and social support. So this is what we tend to call SOS. So strategies, outsourcing, social support. We don't use many strategies in our rehabilitation program. We really have an emphasis on practical rather than visualizing things, and anything to do with the brain. We tend not to do that. We tend to outsource the strategies. So almost all of the memory strategies that we train people in are outsourcing. So taking the strain off the brain, not using your brain, but using something else. And normally it's their smartphone that, you know, I say to patients, your smartphone is now your temporal lobe. So you put everything into your smartphone. You use a diary, you use calendars, you use apps, you use photographs, virtual drug wallets, all sorts of apps that you can get on a smartphone that will actually do what your brain could be doing. So we just outsource to a smartphone. And then the final aspect is social support, which is, again, quite often neglected in traditional rehabilitation models, but that's really using other people's memory to kind of support your own memory. So making sure that the family are aware that you may not remember something if they tell you, and that they need to go and put it into your diary or onto your whiteboard, or they need to send you a WhatsApp message about it or a text message, and using other people's memory to make sure that you don't forget things. So really the aim of our cognitive rehabilitation program in epilepsy is not to restore people's memory at all. It really is to find ways around the nuisance that having a poor memory causes in everyday life. And that really involves understanding why it's happening, accepting that it's happening, and that there aren't any magic answers. Often we will find people who say want to go to the shops and want to be able to remember to buy 5 items, and you will say to them, well, write it down on a list, and then you will bring 5 items home, and they'll say, no, but I want to be able to remember that. And it's getting across the message that you don't need to remember it. What you need to do is get 5 items and bring them home. That's the goal. The goal is to come home with the 5 items. It's not to remember what they are. So moving people away from that is part of the rehab program, and that can be quite difficult for some patients. They can find that quite difficult to accept, because they want to be able to do it. They want to be able to restore function as opposed to find ways around the nuisance. So that would be our basic memory rehab program that we would use for our patients. One of the things that we are very clear about when we are doing the educational part of the program, so talking to people about how memory works and how it goes wrong, is really explaining to them the difference between subjective memory complaints and objective cognitive difficulties that we pick up on our neuropsychological tests. So people often say, why is there such a poor correlation between a cognitive test score, say a list learning score, and cognitive complaints? There are lots of reasons for this, but one of the reasons is that our tests are not designed to assess real life function at all. So in our tests, we don't let people take notes. We don't let people write things down. We control the speed at which the information is coming at them. It's very, very standardized. Some of the tests are deliberately constructed so that you can't easily make associations between the words that you need to remember. So our tests are deliberately constructed not to reflect real life. So that's one of the reasons why there is this mismatch. And the other reason is that patients and clinicians often talk a different language. So patients will complain about memory problems, but actually when you talk to them, you realize it's not a memory problem, it's a language problem, or it's an attention problem, or it's a concentration problem, or it's a fatigue problem. So whilst patients say, I've got a dreadful memory, it may well be that they actually mean they've just got very bad word finding difficulties. So we talk a different language. So we need to be aware of what the patient is actually complaining of, and also that our tests don't reflect real life function. So this is just a little quiz. You can just have a think about the answers, because I can't see your response, but just have a think about what proportion of people with epilepsy demonstrate clinically significant impairment on formal tests. So this is in our group of, this was consecutive patients who were referred to my service. So they've been referred for a memory difficulty, so they're already complaining of memory difficulties. But what proportion do you think would actually score below the second percentile on a verbal memory test? And the answer is about 30%. So more than that, obviously, are a score below the 10th percentile and do have some difficulties. But in terms of very, very poor function below the second percentile, about 1 in 3 of the people who are referred to our service actually have very significant memory difficulties. And then if we think about the proportion of people who report that their memories are a serious nuisance in everyday life, you would think it would be again about 30%, because if you've got 30% who are really struggling on the tests, you think maybe it will be those people who are complaining and saying this is a really significant difficulty. But actually it's fewer, it's about 25%. So that means that at least some patients who are really functioning quite poorly on our tests are not saying that their memory is a significant nuisance in everyday life. But it's actually more than that. There's a real dissociation between patients who report significant memory difficulties and patients who we observe very significant memory difficulties in. So about 23% of people who report that their memory is a significant nuisance don't have clinical impairments. And this may be due to low mood. We know that patients with poor mood tend to report very significant memory difficulties, and that's reflective of their mood. It may be due to expectations, so expecting to have memory difficulties. And it can be due to hypervigilance, where they just become very, very sensitized to any memory difficulties. They also notice normal age-related changes as well. But 72% of people who have significant impairment don't report significant nuisance. And this is perhaps more puzzling, because these people objectively have a very poor memory, but they don't report it's a significant nuisance in everyday life. And one of the reasons for this may be they've lived with it for a very long time, many of these people. So it's their lived experience and very long standing. So they've come up with workarounds already as to why it's not a significant nuisance. So quite often they've already made adaptations and they've got successful workarounds, so it's not a significant difficulty. For some patients with frontal lobe epilepsy, it might reflect reduced insight. So they just don't have enough insight into their memory difficulties to appreciate the nuisance that they're causing. If we look at people who either have very poor memory on our tests or complain very significantly about significant nuisance in their everyday life, it's about half of the people who we see in our department. So cognitive difficulties really are a very significant problem in people with epilepsy. So again, just to go through the importance of accepting that that is part of having epilepsy, and the earlier that can happen, the better. It avoids re-traumatizing somebody with the diagnosis. If they're told everything at the beginning, this is the condition you've got, and this is what it might mean, then they will obviously be going through diagnostic trauma anyway, and they can come to terms with that. They will also be ready to seek and benefit from help earlier if they're aware from the outset that this is part of their condition. Okay, so I'm just going to spend the last 20 minutes or so just talking about how we can use these ideas to prepare people for the cognitive decline that can happen following epilepsy surgery. So we know that epilepsy surgery is a useful and effective treatment for some people with epilepsy, but it doesn't come without risks. So when somebody is weighing up whether or not to go for epilepsy surgery, they will be told that there is maybe a 60% chance of being seizure-free, and on top of that, there may be another 10 or 20% chance of surgery having a significant improvement in their seizure frequency. So those are the good things about epilepsy, that epilepsy surgery, that's why they want to go for epilepsy surgery, why they choose that as a treatment option. And those odds are different for different patients, but generally epilepsy surgery won't be offered unless there is a reasonable chance that somebody will be seizure-free or have a significant reduction in their seizures after surgery. So that's on the one side when they're thinking about it, but on the negative side, they have to think about the risks associated with surgery. And those risks can be quite significant, but can also be quite small. So it's brain surgery, so there's always a chance of death. There is a chance of developing a neurological deficit if somebody gets an infection or a stroke or a bleed during the surgery. There's also the possibility that seizures may get worse after surgery, or that they may change in characteristics so that they're more difficult to live with, so that somebody may perhaps lose their aura and not be able to make themselves safe in a seizure. So sometimes seizures can change characteristic. The chances of all of these things happening are quite small. The patient needs to be aware that they may happen, but the chances are quite small. And then there's the possibility that they may develop a new psychiatric illness. So we know that surgery is associated with the increase in the possibility of developing a completely new psychiatric condition, normally depression, anxiety, sometimes psychosis. So there is a small risk of that developing following surgery. But the thing that we're really interested in is the cognitive deficit that is associated with surgery. And that's slightly different because it's not really a risk of surgery for many patients. It's actually a cost of surgery. It's not something going wrong. It's not something that's unlikely to happen. For many patients, it's actually what we think will happen if you take out that particular part of the brain. So patients need to have accurate information in each one of these domains when they are thinking about going for surgery to make sure that they make an informed decision. And it's really our job as neuropsychologists to make sure that they have accurate information when it comes to the likelihood of a cognitive deficit and what that cognitive deficit may look like. So when we are thinking about poor cognitive outcomes following epilepsy surgery, we're really thinking about 3 classifications. So there are cognitive contraindications, there are cognitive complications, and there are cognitive costs of epilepsy surgery. So I'm just going to go through the difference between those things. So a cognitive contraindication is where there is an unacceptable risk of a loss of function associated with the proposed surgery. So either the risk is too high that something catastrophic will happen, somebody may become amnesic, or they may lose language function, or something else very important, or the risk may be lower, but the actual outcome would be completely catastrophic. So they may become completely amnesic. So generally, it's an interaction between the magnitude of the calculated risk, so how likely is it to happen, and the extent and nature of the anticipated deficit. So how bad is it going to be? And it's an interaction between those things. And that's sometimes the decision of the clinical team. So sometimes the MDT will look at the scan and look at the neuropsychology and say, this person's at high risk of becoming amnesic because we want to take out the left temporal lobe, and the right temporal lobe is already under functioning, and there's pathology there. So it looks like they have bilateral disease. So in those cases, the team will decide the risks are too high. The risks of something catastrophic happening to this person's memory is too high. So it's a cognitive contraindication to going to surgery. Sometimes it's the decision of the patient. So the team may say, well, we can offer you surgery, but we do think there is a risk to your memory. And the person is not prepared to accept that risk to their memory. The team may not think they're going to become completely amnesic, but they may have a significant decline in some aspects of memory, and the patient is not prepared to take that risk. So again, that would be a cognitive contraindication. The patient is not prepared to go forward for surgery. So where there is a cognitive contraindication, patients do not proceed to surgery on the basis of cognitive concerns. There are also cognitive complications. So a cognitive complication is an unexpected cognitive decline. So somebody who deteriorates following surgery that we weren't predicting and we weren't expecting it to happen. Now, this could be the result of a perioperative process. So it may be that something goes wrong during surgery. There may be a bleed, there may be a stroke, there may be infection that actually results in more extensive damage than we were expecting. But sometimes a complication can come from a pre-surgical evaluation which didn't really appreciate what was going on. So this is a case reported by David Loring and his colleagues in America, where somebody became amnesic after a unilateral temporal lobe surgery. And when they looked at the preoperative scans, they had symmetrical hippocampi. So they weren't expecting this person to become amnesic, but when they measured the volumes of them, they hadn't appreciated prior to surgery that this person had very small hippocampi bilaterally. So when they took one away, the other one was not capable of sustaining useful memory function. So they didn't appreciate the volumes, the absolute volume of the hippocampus. They were looking at hippocampal asymmetry in this particular case and missed the volumes. And so that was unanticipated from the pre-surgical evaluation. Sometimes you can have unanticipated consequences of an expected change. So this is a patient of mine who I wrote up a few years ago, who we knew was probably going to have a post-operative decline in spatial memory. She was having a right temporal lobe resection, and actually her imaging was normal and her spatial memory was quite good. So we knew that it was likely that she would have a post-operative decline in spatial memory, and we told her that. What we hadn't appreciated is how important spatial memory and particularly right temporal lobe functions are for the ability to knit. And knitting was one of her passions. So after the surgery, not only was this patient not seizure-free, but she lost her ability to knit. And she used to create these figures, and she could just do this from her, without using a pattern, and she was completely unable to do that after surgery. So for this particular case, it was a complication following surgery, but really we hadn't appreciated, we knew that there would be some deficit, but we hadn't appreciated the application of that deficit. So that's a different type of complication. And then you can have an unexpected cognitive decline that can happen much later after surgery. So if seizures return many years after the operation, you can have a late onset amnesia that can come with the recurrence of seizures. It can come after a period of status epilepticus. There are certain cases that have been reported in the literature of somebody who has undergone a unilateral temporal lobe resection and years later had a traumatic brain injury or developed a tumour in the contralateral temporal lobe and become amnesic as a result of those things. So complications can sometimes be very late and as a result of other post-operative factors. Autoimmune disease is also something that we need to be aware of. So for some patients, if they haven't had their antibodies checked and they undergo surgery, surgery is not going to take away their underlying autoimmune disease. If it comes back, then they can become amnesic if they've only got one temporal lobe left. And this is a case report of somebody where that happened. Okay, so those are contraindications and complications. But what we are really interested in is the costs of epilepsy surgery. So these are the anticipated and expected cognitive consequences of the proposed surgery. And there are lots of ways that we can work out what is going to happen to somebody's memory if we take out a certain structure. Because what happens to somebody after surgery is really just a function of what you are taking away and what you are leaving behind. And there are lots of proxy measures for that equation. So we can look at structural MRI, we can look at the age of onset, we can look at the, the type of underlying pathology, we can think about cognitive reserve, measures of cognitive reserve, the etiology of the pathology and preoperative function. And you can put all of those proxy measures for what you're taking away and what you're leaving behind, the functional and structural integrity of those two parts of the brain. And you can come up with all sorts of algorithms and nomograms that help you to predict what's going to happen to somebody's memory function or language function following surgery. And many of these have been published online. So if you look at Robin Bush's work, she's published all sorts of algorithms where you can put in your patient's details. You can put in how old they are, whether they're going to have, what side surgery they're going to have, their sex, their education, all of these things, what type of surgery they're going to undergo, and press a button and it will tell you their risks of declines in different areas, so language, memory, and even mood now. So very, very useful tools to calculate what is going to happen. But we need to use these algorithms with caution. They look great and it looks like you can kind of predict the future and really, really help the patient to understand what's going to happen. But we do need to be a little bit careful with them. The first thing to be aware of is that these algorithms are based on historical surgical populations. So everybody who's been through the surgery program so far, and quite often they are based on older cohorts because they need to have been followed up for at least a year. And one of the problems in epilepsy surgery is that the patients that we operate on now do not have the same characteristics as the patients we operated on 10 years ago and 20 years ago. So we are operating on patients generally who are much more complicated nowadays. It used to be that 9 out of 10 patients had hippocampal sclerosis. It's quite rare now to just see a simple, straightforward hippocampal sclerosis case. So we need to be aware that the groups, the samples that these algorithms were developed on are not the same as the patients that we see now. We also need to be aware that certainly the American published algorithms are based on very specific tests that have culturally based norms. They have American norms. They're not the same as the ones that we use in Europe. And the other thing about these predictions is that there is a very specific time frame. So they're predicting outcome at 1 year. And we know that that can change quite significantly. So we might be able to be very clear what will happen to a patient at 1 year after surgery, but really they want to know what's going to happen in the longer term. So just a few caveats. They are a great clinical tool and they can be really, really helpful, but they're not. They don't. We need to be a little bit careful and use some clinical common sense when we're using them. The other problem with using those algorithms is if you don't use that particular test, then you can't use the algorithm. So if you don't use the Boston naming test or you don't use the Californian verbal learning test, then you can't just put your naming score into the algorithm. It doesn't work. So another way that we can look at who is at risk following surgery is just to look at some of the red flags that are reported in the literature. So there are a number of papers that have reported risk factors for a decline in cognitive function under surgery. And those factors include older age, a dominant temporal lobe resection, normal imaging, and things like that. So we can also just look at red flags. Once you've got a picture of what you think somebody's memory is going to look like following surgery, you can actually plot out what the areas that you think are going to decline following surgery and the areas that you think are going to stay the same following surgery. And actually you can also plot the areas that you think may improve following surgery. There are some algorithms that predict improvement in function following surgery for some patients. So you can have a prediction of what's going to stay the same, what's going to get better and what's going to get worse. So it's really a look at what that person's neuropsychological profile might look like after surgery. And if you've got that, you can then use that to plan for any expected deficits that you think will happen or think will occur after surgery. So again, it comes back to using that SOS toolbox that I talked about at the beginning with the cognitive rehabilitation. So if we have somebody who is going to undergo a left temporal lobe resection, and we think from looking at the algorithms and the red flags and their current function and all of their risk factors, we think there's a high chance that they're going to have increased word finding difficulties after surgery and that their verbal memory is going to go down after surgery. So they're going to have a deterioration in verbal memory. That's our prediction. So what can we do with that? Well, we get them in and we talk to them about what that would look like in their home life, at work, and in social situations. How might that prove difficult? Where is it going to be problematic for them in each of those situations? And then we look at how we might reduce the possible nuisance that those difficulties might cause in each one of those domains. And then we start to build in the structures and routines and strategies that they will need to use to get round those anticipated difficulties. And we do that prior to surgery. There is no need to wait until the person has the deficit to try and get all of those routines in place. So we use the memory function before they lose it to actually get all of the strategies and routines in place so that they're in place, they're already using them. They're part of their everyday life before they go to surgery. And then it's in place already when they come out of surgery and they sustain the deficit. So what are the limitations to that kind of approach? Well, I talked a little bit before about the time frame. So when we use predictions, we tend to just look at where somebody's going to be 1 year post-operatively. And the reason for that is because cognitive change after epilepsy surgery is very dynamic. You tend to get a drop in function to about 3 months after the operation, and that's just a function of the surgery. You then get a gradual decline up to about 1 year, and then things will begin to plateau at about 2 years. But that's if you look on a group level. If you look at individual levels of function, you'll see very different trajectories. So some patients may get better and better, and they may actually end up with improved function compared to baseline, particularly if the surgery has resulted in a significant reduction in subclinical activity. For some patients, they may get really quite worse after surgery. So that may reflect another seizure focus starting. It may reflect the return of seizures. It may reflect mood. And for some patients, they may really fluctuate after surgery. Again, that may reflect mood effects. So one of the problems with predicting outcome is that we tend to predict based on a group norm. But for patients, they're not interested in what the average is. They're interested in which one of these trajectories are they likely to follow. So that's something that we're working on now, really to look at what predicts a recovery trajectory as opposed to an end point. So just to finish with some take-home messages for you. First thing is that in epilepsy, seizures are just one manifestation of an underlying brain abnormality, and cognitive problems are an integral part of the condition for many people with epilepsy. Treatments aimed at controlling seizures can exacerbate existing cognitive problems, and they can also create new ones. And cognitive difficulties in people with epilepsy are present every day, and they deserve the attention and treatment from their doctors and their psychologists. This is not something separate from seizures. It's another manifestation of the underlying pathology. When we think about epilepsy surgery, it's associated with a decline in cognitive function in more than 1/3 of epilepsy surgery candidates, particularly if we take into account their preoperative capacity to decline. Some patients are already on the floor of our tests, so we don't pick up their decline. That doesn't necessarily mean they're not declining, but it just means that our tests aren't sensitive to it. The nature and the extent and the risks of that decline are not just based on the nature of the proposed surgery. It really depends on the individual. So it's the individual's preoperative characteristics that play an important role in their risk profile for cognitive decline following surgery. And when we're looking at epilepsy surgery, prospective candidates must be given accurate information about the likely impact of surgery on their cognitive function, so they can actually make an informed decision about surgery. We need to give them accurate information about all of the risks and all of the benefits. We can calculate and quantify risks of cognitive decline on the basis of an individual's preoperative clinical and demographic characteristics. We can look at the impact of the likely postoperative changes on an individual's life prior to surgery, and we should explore that fully with them prior to surgery. And we can use preemptive rehabilitation, prehabilitation, to prepare surgical candidates for any expected deterioration in function. And this is really the main thing. We do not need to wait for an anticipated decline to start to implement the strategies to reduce the impact of that decline on their function. And I'm just going to finish by just saying, if you wanted to learn more about neuropsychology, rehabilitation, assessment, treatment, the International League Against Epilepsy does run a course in France every couple of years. The next one is in March next year, and there are still a few places left. Just go to the International League Against Epilepsy website and you'll be able to find details about that if you are interested. And I'll finish there. Thank you.
Thank you so much, Professor Baxendale. I really appreciate your time spent in this talk, and moreover, the knowledge provided on this, I think, hot topic in neuropsychology, about neuropsychological comorbidities in epilepsy and its treatment for non-pharmacological way or point of view. I was delighted to hear from you, and I'm sure from all of attendees. Indeed, I guess it's the time to open the floor for questions, doubts, or comments. All of the people, you can write your comments and through the chat, please. Or translator will kindly traduce or transfer each comment. In the meanwhile, I would like to highlight some points that I think are interesting in our film, and I want to discuss more of them. Okay, I will start with them. I think we are aware to the great progress in the fields such as MRI, for example, or neurosurgical or minimal invasive techniques. And I think in the field is the field of rehabilitation or rehabilitation in cognitive function, or area of learning or development. What do you think about?
Okay, so in terms of functional imaging, I think it's really interesting with functional imaging because it's a very well funded area of study, and there are many studies that have looked at different fMRI protocols that can predict outcome and that predict the ways that the brain can adjust and reorganize functions after surgery, and it is an exciting field, and it's something that is really developing very fast. But when you look at those studies, whilst the imaging side of things is very technological and very advanced and very complex, what they are actually predicting hasn't changed since probably 50 years. They tend to be predicting one score on one test, and they say that's cognitive outcome. And actually, we know as neuropsychologists that if we just look at one score on one test, there are lots of reasons why somebody may have done poorly on that test. And changes in that score could represent all sorts of things. They might represent low mood. They might represent just overall intellectual ability. There's all sorts of things that are not taken into account with functional imaging paradigms. And I've just written a paper about this, actually, just trying to get the functional imaging people to take a little bit more notice of the outcomes that they are predicting and put a little bit more work into making sure that what they are predicting is meaningful for the patient, as opposed to just a score that actually probably doesn't mean that much. And if we're going to use it in terms of preparation and prehabilitation and something that actually is clinically useful, I think we need to give a bit more attention, not to the fancy paradigms that they're using in the scanner, but more to what are you predicting with that and how can we actually apply that? Because I think that at the moment there's a mismatch, and it's getting the gap between the predictor and the outcome is just getting bigger and bigger. The predictors are getting more and more technologically advanced and very, very sophisticated, and the outcome is one score on one test, and that's not good enough, and that's not helpful for our patients. So yeah, I don't know if that's the answer you wanted, but
yeah. For sure. Thank you so much. Okay. I changed the language, okay. Blanca, ¿me escuchas? Blanca.
Sí, Carmen, perdona, creo que Blanca te escucha, pero como está en el idioma catalán no la puedes oír.
Vale, voy leyendo las preguntas de la audiencia.
ok.
Ok. Uno de los asistentes da las gracias, ¿no?, a la doctora Baxendale, y le gustaría hacer una pregunta en relación a los test de memoria audioverbal de listas de palabras. A veces los neurólogos nos exigen un diagnóstico localizador. Nos pregunta cuáles son los puntos claves que recomendaría prestar atención para diferenciar una alteración de memoria de origen disejecutivo frontal versus un perfil de disfunción temporomesial, más bien hipocámpico. ¿Es siempre posible hacer un diagnóstico topográfico en este sentido o no es recomendable hacerlo? Por ejemplo, cuando tenemos una resonancia magnética sin alteraciones.
Okay, so that's a really, really good question. So we're really looking there at the difference between what would a memory difficulty with an organic substrate in the temporal lobe look like compared to memory problems with maybe a more frontal etiology. And I think the answer is that there is no one score on a list learning task that will tell you that. But there are lots of hints that you can get from a complete neuropsychological assessment that might tell you that the problem that you're looking at is more frontal or more mesial temporal. So what I would be looking for in a frontal picture is evidence of confabulation on the list learning task, so lots of intrusion errors. I would be looking for evidence of dysexecutive function and in disinhibition and other features in other tests, that there may be something more frontal going on. And in particular, what I've tended to find is that patients with frontal lobe epilepsy tend to be more, they tend to have difficulties paying attention. So their concentration isn't good. And you will see that across the assessment. Sometimes they can focus and then sometimes they just lose attention. So it's not that we are looking at a single score on the list learning and we can say if they can't do it, then it must be temporal or it must be frontal. It's much more how somebody is experiencing the difficulties. Is it due to this executive function, or in a more temporal picture, is it that they just have difficulties encoding that new information and it's a focal deficit? So it's how that score sits in the whole profile of neuropsychological strengths and weaknesses that will tell you whether it looks more frontal or whether it looks more temporal. But it's, I think there aren't any, it's not like you can look it up in a table of norms. It's much more experience and a feel for how the patient is failing. It's a really good question because it's something that my younger psychologists will say, well, how do you know that? And sometimes you just get a feel for how the patient is failing. And that's what I'm always looking for, is not whether the patient can do it or not, but why can't they do it? What is the issue? Is it an executive problem or is it a memory problem?
Perfect. Thank you, Professor Baxendale. Tenemos otra aportación de otro asistente y nos comenta que cuando realizó sus prácticas de neuropsicología, si los pacientes jóvenes no tenían deterioro cognitivo significativo, eran candidatos a cirugía. De lo contrario, no los operaban. Él pregunta que por qué. ¿Existe un perfil neuropsicológico de un candidato a cirugía para la epilepsia? Esto, bueno, cuando nos dedicamos a neuropsicología de epilepsia en contextos de cirugía de epilepsias, tenemos muy claro estos últimos conceptos, ¿no? que hablábamos de la reserva cognitiva y de la adecuación funcional en casos de pacientes con epilepsia del lóbulo temporal, pero en cuanto a la edad y el deterioro es algo que habría que estudiar independientemente y que solo en este caso se circunscribe a pacientes con epilepsia del lóbulo temporal. En otros casos, por ejemplo, ¿cómo podríamos valorarlo?
Okay, so I think there's two issues there. The first is from a neuropsychology point of view, we are interested in the onset of seizures, but we are also interested in the onset of the pathology that underlies those seizures. So for some of our patients, they may not develop seizures until they are 10, 15, maybe into adulthood. But when we look at the pathology, we know that has been there from the beginning because they might have a focal cortical dysplasia or something. So we know that their brains have developed or their functions have developed around that underlying pathology. So they will have different brains and the organization of function will be mapped differently in their brains to somebody who has a later onset of pathology, so that their brain developed normally and then the pathology came afterwards and attacked the normal development. So there are two issues psychologists are interested in. One is when the seizure started, and two is when did the pathology start, because it's really that pathology that will tell us about the mapping of function. And in terms of how young somebody should be when they have epilepsy surgery, the latest guidelines indicate that the younger the better, because there's more plasticity for young people and they tend to do better. So I think whilst it used to be the case that they would only do epilepsy surgery on people who were quite intellectually disabled and didn't really have much function to lose, there is a move towards doing epilepsy surgery much younger, even in patients who are doing quite well cognitively, because we can get rid of their seizures and the rest of the brain can start to adapt to that loss of function whilst there's still maximal plasticity. So there is a move towards doing surgery younger. And ideally, you would want to be doing surgery really mostly in children, not in adults, because they don't have any plasticity as adults. It's too late, really, once they get to adulthood. So if they have a pathology that you know is going to be associated with medically intractable seizures, really doing them early is better.
Perfecto. Ahora, por ahora no tenemos otras preguntas o comentarios. Si alguien más se quiere animar, todavía tenemos un ratito de tiempo. Y bueno, mientras tanto aprovecho y bueno, voy comentando algunos puntos que me parecen interesantes y que creo que también a los asistentes puede interesarle, como es hasta qué punto la prehabilitación actualmente podría evitar realmente un déficit postquirúrgico, evitarlo por completo, o más bien el punto de lo que comentaba la profesora Baxendale, no es restaurar quizás la función, si estamos hablando ya de un déficit instaurado, sino hacerlo parte de nuestra rutina mediante estrategias compensatorias, ¿no? Al final es un poco evitar el resultado, el síntoma, nuevamente, que sería a nivel cognitivo, mediante estrategias, ¿verdad?
Absolutely, absolutely. So often we can't avoid the deficit. I mean, there are certainly new strategies, surgical strategies out there that are trying to minimize the cognitive consequences of surgery. So some of the, I think the laser surgery is looking very hopeful because it avoids the collateral damage of the lateral structures that you get with a normal resection. So I think the laser therapy is hopeful. And there are certainly some of the more selective procedures are trying to preserve as much cognitive function as possible. But for many people, it's inevitable that if we go into the brain and take out that part of the brain, we will disrupt function. And there is nothing that's a law of physics that's going to happen. So it is exactly as you say, it's coming up with the compensatory strategies, making sure they are in place so that the person is still able to function and still able to achieve the goals that they need to achieve. They will be doing it in a different way, but they will still be able to achieve those goals. And that's what our job is, to make sure that they are still able to function.
Finally, is the cost of all neurosurgery technique or via is the cost.
The cost
is a normal cost, cognitive cost of neurosurgery. Is a minimal cost or as you told, complications.
Yeah,
that we done unexpected.
Yeah. So for all patients, all of those, the costs, the complications, the contraindications, they are different for every patient. And I think again, this is where we can help to educate our neurological colleagues, because they are, and our neurosurgical colleagues, because they are very used to the idea of a standardized procedure. So they will talk about a standardized resection or a standardized procedure. But in neuropsychology, there is no such thing as a standardized procedure, because the same procedure will create different results in different people. So we need to make that clear to our colleagues that when it comes to neuropsychology, every individual is different. And although they may be doing the same operation, the costs, the complications, the contraindications will all be different. And we need to work that out for that patient and tell that patient what their individual risks are, because the group average is not helpful. They need to know what their individual risks are.
Yes, totally agree. And I take your message of train your neurologists.
I think that's the best thing we can do, is train our neurologists. Yes, it's hard. It's very hard.
It's very important, because in my opinion, most of patients come to the visit and they don't know why are there. And I think, okay, I spend my time, because I think it's super important to explain the main objective of the evaluation, of the assessment, and the cognitive correlate. I should say of pathological areas.
Yeah. So many of our patients, when I see them, when they have been referred for a memory assessment, they think they are coming for me to make their memory better. And it takes a long time to get to the point where they realize, I cannot make their memory better. I can help find ways around the difficulty, but I cannot make their memory better. And I think if we start at the very beginning of the patient journey, we can avoid that.
Yeah. Okay. We don't have any comments, and I think could be enough.
Okay.
And in closing, I would like again to thank you, Professor Baxendale, again for all the knowledge you provide us, and all of the attendees for their participation. I hope all of the people here found it interesting. I think for me, super interesting and needed for my clinical practice. We will continue to advance in the field of clinical and research in neuropsychology in epilepsy, and I think this is aligned for our learning, the prehabilitation, the point of the patient are individual in each case, and it's very important to don't fall in the standardized protocols and standardized surgeries and reports. And I think this point of view is very important, and the acceptance of the condition in all of the patients, because neuropsychological comorbidities are frequent in all of the patients, and we can work with this. And the expectative or expectation of the patient around her performance or then performance after or before elsewhere treatment, surgery or pharmacological, for example. And I think it's very important for us to take these messages.
Great.
Thank you for all.
Thank you very much, and thank you to everyone for staying and listening.
Per la nostra banda, també volem donar les gràcies a la professora Sally Baxendale per la seva conferència tan interessant, i també a tu, Carme, i a tots els assistents per la seva participació. Moltes gràcies i us esperem a les properes activitats del COP. Bona nit.
Okay. Thank you so much.